like to acknowledge the traditional owners on the land in which we're meeting today and pay my respects to them, their elders past, present and emerging, and to any Aboriginal or Torres Strait Islander people that might be in the session with us today. I'd like to first extend a warm welcome to Emily Hislop. Emily's session today will address the conflicting nutritional advice that is available everywhere, and it can be difficult to know what to trust after a cancer diagnosis. This presentation takes a deeper dive into some of the most common nutrition myths in cancer care, exploring what the latest evidence says about popular nutrition claims and where the research currently stands. Emily will also highlight the evidence-based nutrition advice that people affected by cancer should prioritise, helping attendees feel more confident in navigating nutrition information and making informed decisions. This presentation may prompt some questions that may require some individual support. We welcome these questions offline, but any questions directly regarding the session today can be answered at the end of this session. So over to you, Emily.
Thanks, Alison. I'll be presenting evidence on nutrition messages in cancer from a dietitian perspective. The objectives today are to describe what a dietitian focuses on in cancer care. I think it's important to make that clear before I summarise the latest evidence on nutrition kind of like trends such as sugar, ketogenic diet, fasting around chemotherapy, supplements, clean eating, and nutrients that might aid healing. I'll also do a bit of a summary on evidence for reducing cancer risk with nutrition, including recurrence, and introduce the new dietitian service at Pancare. So I've been a dietitian since 2020. I graduated from Monash in Melbourne, and then I did some private practice work. I worked in hospitals in regional New South Wales and remote Queensland for a year. Then I went up to the Kimberley at the top of WA, and I worked as a community dietitian in remote Aboriginal communities. So that was a lot of community engagement, nutrition promotion, and clinical dietetics as well. Then last year I started at Pancare as a project officer on the Diet Hub project. So I was in a team and we were creating more tailored nutrition resources for people with upper GI cancer, and that should be going online by next year. That was super interesting because when I came on board, they just finished a consultation phase where they'd surveyed dietitians, upper GI cancer nurses. They'd interviewed patients and carers. I don't know if anyone here today was involved in that, but I kind of went through all of that data and cleaned it and summarized it. So that gave me a lot of insight into this patient group, and really motivated me to start in the dietitian position that was just created last month. Yeah, so I've been doing this job for 6 weeks approximately. So with dietitians, we always try and complete a comprehensive nutrition assessment with each patient. What you focus on in that assessment kind of varies depending on your role. For example, I'm currently working via telehealth, so I don't necessarily have access to people's blood test results like I would in a hospital. But generally, the assessment includes collecting anthropometric data, so things like weight history, biochemical data, clinical, dietary, social data, and kind of using that to make a nutrition impression or a nutrition diagnosis. So it's important that we understand what's underlying that diagnosis. So if somebody's severely malnourished, is it because of malabsorption because they weren't educated on how to use their creon properly? Or is it because they have a really ulcerated mouth? And then we kind of focus on that and provide individualized nutrition advice and work with the multidisciplinary team to help them kind of optimize nutrition as well. So nutritionists are different to dietitians. Nutritionist is not a defined or protected term. It doesn't indicate any particular education or certification. So I've certainly met nutritionists that are very knowledgeable, but If it's important to you that the clinician has kind of formal education and accreditation, I would recommend a dietitian. So most dietitians in Australia, like newish dietitians, would have a master's degree. Anybody working outside of a hospital needs to become accredited. So you get a mentor who's an accredited practicing dietitian. You work with them for a year. And then to maintain that accreditation, you do at least 30 hours of professional development each year. So, a dietitian's focus in cancer care is mostly to reduce the impact of cancer-related malnutrition. So that malnutrition, it can arise from the tumor itself, and it also comes from the effects of the cancer treatment, whether that's chemo, radiotherapy, targeted therapy. All of those treatments have side effects, which can affect somebody's ability to eat. So things like loss of appetite, nausea, mouth ulceration. The effect of these factors combined makes adequate nutrition intake difficult, which can lead to unintentional weight loss and eventually malnutrition, which has a number of serious adverse outcomes for people undergoing cancer treatment, including like poorer survival, quality of life, reduced ability to complete treatment, maybe greater post-op complications, poorer functional status, things like that. So up to 70% of cancer patients are affected by malnutrition, and this number, I would say at least 80% of upper GI cancer patients are affected by malnutrition. So what's happening to somebody's metabolism and nutrition requirements during cancer? The tumor itself produces things like cytokines and other agents that create systemic inflammation, so like whole body inflammation. The effect of that systemic inflammation is that the body needs more energy and protein to function. The inflammation to that extent can also alter the body's ability to efficiently use the energy and protein it's getting. That doesn't happen in everybody, but any GI cancer patients are at fairly high nutritional risk. And tumor type aside, undergoing treatment will always increase somebody's energy and protein requirements. Alongside GI cancer patients, people with head and neck cancer, lung cancer, some hematological cancers are at higher nutrition risk. So dietitians play a part in improving body composition, which tends to change dramatically for cancer patients. The statistic is that 30 to 60% of cancer patients are sarcopenic. Sarcopenia is when you have a low quality and quantity of muscle. The reason this matters is that it's kind of similar to malnutrition. It can lead to longer hospital stays, slower recovery, increased treatment toxicity and side effects. So if, say, like 80% of a group are malnourished, perhaps half of them are also sarcopenic. So if you have more severe malnutrition, you've probably got more muscle loss. People don't necessarily present as like a classic case, so they might not be visibly malnourished. There are figures published across different studies where they've used computer tomography scans to look at cross-sectional areas of the body and compare muscle mass across people with different body mass index, so people of different sizes. And they've found that people with identical muscle stores can have vastly different BMIs. I think some of the source of confusion when it comes to nutrition messages is that nutrition priorities can change across all individuals, but across different cancer groups. So with body composition in mind, like people with breast and prostate cancer are often getting hormonal treatments, which can make weight gain more likely. But that weight gain is often mostly fat gain. So those people can still be sarcopenic. I suppose that the key point is that when you lose weight unintentionally with cancer, and you become malnourished, it's the muscle loss part of that weight loss that drives the adverse outcomes. And that's why dietitians talk so much about protein in combination with exercise as a treatment for malnutrition and sarcopenia. There's a lot of really recent research in sarcopenia, and it shows that the exercise actually has more of an effect in treating the sarcopenia than nutrition does, but ideally you'll do both. So now I'll talk a bit more about the specific like myths, trends, messages about nutrition for people with cancer. Before I talk about that, I'll just give a little bit of an overview about carbohydrates. I think it's difficult to interrogate these nutrition messages about things like the ketogenic diet and fasting and cutting out sugar if you don't have some kind of foundational knowledge on what a carbohydrate is. So, sugar comes in many forms. In its most simple form, it's a single molecule like glucose. Then you've got other single molecules like fructose. If you put glucose and fructose together, you get sucrose, which is like white table sugar. When you start putting more of these different sugar molecules together, they kind of lose their sweetness and become a more complex carbohydrate. And they're those starchy carbs like bread, rice, pasta, potatoes. So our bodies are made of millions of cells, each with different jobs. And something that all of those cells have in common is that they use glucose to make energy so they can do their job properly. So if you have something obviously sweet and sugary, like a soft drink or an orange juice, your cells kind of absorb that glucose from that fairly quickly. If you have more complex starchy carbs, they're broken down by enzymes in saliva and digestive juices into glucose, which is then taken up by the cells. So that's why if you know somebody who's a diabetic, it's not just that they're reducing their intake of like sweet foods and indulgent foods, they're also managing their portions of starchy carbs because those starchy carbs ultimately break down into sugar anyway. Yeah, so one of the most common things I hear in cancer nutrition is that sugar feeds cancer. So there is a little bit of science behind where this idea comes from. So cancer cells are like rapidly growing and dividing cells, so they need a lot of energy. And many cancer cells, because they need a lot of energy, are taking up more glucose than healthy cells. So from that observation comes this kind of logical sounding theory that if cancer cells need lots of glucose, perhaps we can starve the cancer by stopping eating sugar or carbs. So the problem is that our bodies don't really work like that. So we can't tell the body to kind of send glucose to healthy cells, but don't send it to cancer cells. It's really important to have glucose to fuel the whole body, and the body works quite hard to maintain glucose in the bloodstream. So even if you completely remove sugar and carbs from your diet, your body will still find a way to make glucose. So it can use components of protein and fat to produce the glucose it needs. So it's kind of impossible to starve a tumor of glucose by not eating carbs and sugar. And if somebody isn't eating enough overall, the concern is that the body starts drawing more heavily from its own stores. So using fat stores and potentially muscle stores. And this can contribute to like existing kind of weight loss and malnutrition risk that we already talked about. The other important thing is what we actually mean by like sugar. So when people hear sugar feeds cancer, yeah, they're often thinking of those like indulgent foods like chocolate, honey, cakes, soft drinks. But like I said, all carbs break down into glucose anyway. So trying to eliminate any source of glucose means eliminating a lot of food groups. And for people already struggling with side effects like low appetite, mouth ulceration, pain when eating, just general unintentional weight loss, restricting your diet that much can just make it really difficult to meet your nutrition requirements. So yeah, like cancer cells do use a lot of glucose, but so do healthy cells. And avoiding sugar and carbs doesn't selectively deprive the cancer of its fuel. Then this idea leads nicely into the next slide about the ketogenic diet. So it's very similar. Like a ketogenic diet is very low in carbohydrates and higher in fat. The idea is that instead of cells using glucose to function, the body will use the fat you eat and fat stores to create ketones, and the cells use that for fuel instead. There's also a theory that like the cancer cells like rely really heavily on glucose and they might not be able to use those ketones efficiently like, other healthy cells in the body can. So it's that same idea of like selectively depriving the cancer of fuel. Most of the positive evidence on the ketogenic diet, so the studies that showed good things, they were generally like in vitro studies or animal studies, so they weren't human studies. The human studies that have been done are small and varied and often poor quality. So a robust study is usually like a randomized control trial where you've got one group who's doing a ketogenic diet and a control group that's just eating like a more normal diet. So we're really looking for randomized control trials to get strong evidence as opposed to these like small kind of varied trials. That's what I mean when I talk about poor quality evidence. Yeah, so the research shows that there wasn't any evidence that the keto diet shrinks a tumor or improves survival. I think there was a dietitian who did a report on a bunch of studies and talked about how fiber intake was a challenge. So it was reported that some people had low fiber intake, which can lead to constipation. Some participants lost weight as well and found the ketogenic diet difficult to follow. And as I mentioned, weight and muscle loss during cancer treatment is not ideal. So the bottom line is that the ketogenic diet is not recommended. Something else that came up in the studies is that they couldn't really define what a ketogenic diet is. So that's another reason that these studies weren't well controlled and that the evidence wasn't strong. So in some studies, people had, 5% of their diet was carbs. In other studies, 20% of their dietary intake was carbs. And like the proportion of other macronutrients like protein and fat varied as well. It's also really difficult to identify if somebody's in ketosis. So like one person might need a lower intake of carbs for their body to start making ketones. So it's just a lot of variation. The adherence and side effect issues I already talked about. And I mentioned the weight loss as well. So I think it's important to keep in mind that for the upper GI cancer group, or generally GI cancer group, it's really important that the evidence, is really strong because upper GI cancer patients are a high risk group, as opposed to, say, the breast or prostate cancer group I was talking about before. Another idea you might have come across is fasting before or around chemotherapy to make the chemo more effective. This is kind of like niche and new, this research. There's a lot of early data. Similar to keto, there's a lot of like in vitro and animal studies. There's a small number of human studies, and they were done in people with ovarian and breast cancer. So the findings are from very small groups, and it's difficult to draw comparisons to other tumor groups. So we can't just say, oh, because it worked for people with ovarian and breast cancer, it will work for people with upper GI cancer. So similar to the keto studies as well, like there was a lot of variation in the diets that people actually followed. So some people fasted for much longer than others. So some people were just fasting for one day, others were fasting for longer. Some studies were having like absolutely no nutrition while they fasted. In other studies, people were having like small amounts of nutrition from broth or like beverages. So it's again difficult to define what intermittent fasting for chemo is. Some outcomes were positive, like they showed increased treatment tolerance, reduced treatment related side effects like less bloating, diarrhea, constipation, and fatigue. There were some reports of improved quality of life. So these all sound positive. The problem is that it can be dangerous. And that's where we have to be careful. These studies didn't include people who already had a low BMI or had recently lost weight. None of the participants had diabetes or heart disease or eating disorders. So it was a fairly like strong, healthy cohort. So many people struggle with eating during chemo and from the side effects of chemo and lose weight. So it's really important that these groups of participants do represent like upper GI cancer patients and malnourished patients, and they didn't. So, as a general rule of thumb, I wouldn't recommend this. If it was done, it would need to be one-on-one. You'd need a lot of support by an oncology dietitian and work, really closely with them to kind of track any weight changes. As I've discussed, like muscle mass is so important, and we don't want you to be losing weight and losing muscle. So there really just needs to be more studies come out before like recommendations are made around intermittent fasting. Also, some participants did report negative side effects like hunger, weakness, nausea, dizziness, weight loss. So you'd want participants who are physically fit and like a favorable weight to start with. So it just makes conducting these studies a little bit difficult. So another trend that I hear about is clean eating. So particularly the idea that once you have cancer, you should be cutting out processed foods and eating only whole foods. It's a little bit kind of more nuanced because, of course, diet quality does matter. So a dietary pattern containing plenty of whole grains, fruit, vegetables, legumes is something that we encourage for people who don't have cancer to reduce their risk of developing chronic disease and increasing their risk of cancer. And there are good reasons to do this, and there are good reasons to kind of limit your processed food intake. But nutrition during cancer treatment can be like very different to nutrition for cancer prevention. As dietitians, the first thing we need to establish is like, is this person actually able to meet their energy and protein requirements? And remember, the energy and protein requirements are very high. So someone might be losing weight, losing muscle, have very little appetite, feel full after a few mouthfuls, or be dealing with other side effects. And in that situation, telling them that everything they need to eat, that they should eat, needs to be fresh, whole, and minimally processed can actually make eating more difficult and more restrictive. So that's why you might have had dietitians tell you to just eat anything, like eat whatever you can manage. And it doesn't matter if those foods don't fit this picture of clean eating. And processed food, it doesn't automatically mean that the food is nutritionally poor. Like processing is a very broad term. It's just like a little bit of a blunt message to encourage clean eating during cancer. There's kind of a hierarchy. So you're working out if somebody's getting enough food and meeting their energy and protein requirements and protecting their weight and muscle mass. And once people are achieving that, then it creates more room to look at like the quality of the food. So when I talk to people about fortifying their meals and snacks with more energy and protein, if they're doing really well, I will talk about, oh, what are some healthy sources of fat? Like, so maybe instead of using butter, use like olive oil or avocado or hummus. If they are able to eat a range of plant foods, I would encourage that. And I would encourage fiber if they don't have diarrhea. And um, yeah, like I would talk about good quality protein sources as well. So it's not just meat that is a good source of protein, it's also like beans and legumes and dairy and nuts. Yeah, so there's been a bit of research done on like dietary patterns during cancer treatment, but yeah, there's not a lot of evidence out there at the moment on that. But that would be interesting to know. So another really common question is, should I be taking supplements during treatment? So supplements aren't automatically like harmless. So it's really, really important to basically ask your treating team if the supplements you're taking are okay. Some supplements interact with cancer treatments, depending on the chemotherapy drug and the particular supplement. They can maybe alter the way the treatment works or increase its toxicity. An increased sensitivity to chemotherapy isn't necessarily a good thing. Like we want chemo to have its intended effect on the cancer cells, but if something also increases its effects on healthy tissues, that could mean more treatment-related toxicity and side effects. There are particular chemo regimes where the oncology team may advise against certain vitamin or mineral supplements. This is often regimes containing drugs like 5-FU. So rather than making a blanket recommendation about supplements, it really needs to be checked against the person's individual treatment. It's also particularly important if you're participating in a clinical trial that you check with the treating team. You might specifically be asked not to take supplements because interactions with a trial drug may not yet be fully understood. And researchers need participants to be treated under similar conditions so they can accurately work out the effects of the treatment being studied. So yeah, the practical message is make sure your treating team knows about everything you're taking, whether it's vitamins, minerals, herbs, powders, probiotics, and other complementary products, rather than assuming that something is safe. Probiotics are another supplement people often ask about. There's been some interesting research looking at diarrhea during chemo and radiotherapy, and some small studies have found that people taking probiotics experienced less diarrhea, felt better, needed less medication to manage their symptoms. So that's promising. But many of those studies have been small, and there isn't enough like consistent, high quality evidence to routinely recommend probiotic supplements for people during cancer treatment. There's also like this distinction between foods containing live cultures and then concentrated probiotic supplements. So foods that you might normally eat that contain probiotics, like yogurt with live cultures or kombucha, can be an appropriate way to include probiotics in your diet during treatment. That's normally fine. It's more the high dose probiotic capsules or any probiotic supplements that are different. They just contain larger quantities. Or particular strains of microorganisms, and we don't necessarily know how they'll interact with someone's treatment or immune status. Yeah, so the overall message is just check before you take. Is there a nutrient that aids healing? I've talked about protein on this slide. It's not because protein itself treats the cancer, but it's just because it's really important for maintaining and repairing the body. So, yeah, protein really provides the building blocks we need for tissue repair, immune function, and maintaining muscle mass. It kind of reminds me of the slide earlier where we talked about sarcopenia and how common muscle loss is in people with cancer. And importantly, that it's the loss of muscle rather than like just the loss of fat mass that's particularly associated with poorer outcomes, including slower recovery and greater treatment toxicity. So a big area of research at the moment is how to treat sarcopenia, and that the combination of a high energy and especially high protein diet combined with exercise is recommended. So eating a high protein diet alone won't protect you from muscle loss. Um, in terms of exercise, it doesn't have to be this kind of intentional going for a long walk or going to the gym. It can really be anything around the house. You could be using hand weights while you sit down. It could be walking up and down the hall. You might want to go on YouTube and find like a chair yoga video. So, yeah, keep in mind that any movement counts. Also, keep in mind that protein is, I mentioned this before, it's not just meat. It comes from eggs, fish, chicken, red meat, tofu, beans, legumes, even things like soy sauce have protein in them. Now I'll talk a little bit about cancer prevention. So after cancer, the way you eat might be significantly different to what it was before you had cancer, especially with GI cancers. You might not be able to eat as much, or your body might react differently to certain foods. It's just important to work with what you can manage. And then if you have the capacity to gradually incorporate recommendations. The research shows it's probably stuff that you've heard about before, but fiber is really, really important. So it's recommended that you limit your intake of red meat to maybe like up to 500 grams a week, or I generally say like 1 to 2 serves a week. Whole grains, fruit, vegetables, beans, and lentils are highly recommended. So you want to be having those in as many meals as possible if you can. And it's really the fiber component of those foods that's protective. It's recommended to limit processed meat and to limit alcohol intake. The evidence around dairy is varied. I think there's evidence to say that it's protective against, I think, colorectal cancer, but it can increase your risk of prostate cancer. So maybe just have dairy in moderation. And like I said, sometimes people will have, a stoma or really altered GI function after cancer, and might require dietitian advice to be able to incorporate some of these recommendations. I think the gut microbiome in cancer prevention is a really interesting area. For those of you who don't know, the microbiome is just the environment of like bacteria all through your gastrointestinal system. So, the good bacteria, the bad bacteria make up your microbiome, and any maybe like fungi or viruses. What we do know is that H. pylori increases cancer risk. I'm not sure if anyone would have heard of H. pylori. It's not necessarily part of like the normal gut microbiome. It's more like a bacterial infection. About half of the global population have it, but it's a lot more common in developing countries. So it lives in, I think, like the lining of your stomach, and there's strong evidence to say that it increases cancer risk. There's a lot less certainty about like causation and the overall gut environment when it comes to cancer risk. I think the question the studies are really asking is, could the microbiome help explain why people with similar lifestyles and genes have different cancer rates? A lot of the evidence is not in human studies. When it comes to improving your gut microbiome, it's not all about, but fiber is a massive focus. So it's kind of a dietary pattern that overlaps with the existing cancer prevention advice. And adding probiotics to your diet can be really beneficial as well. So probiotic foods like, kefir, yogurt, sauerkraut, kimchi, kombucha. Limiting alcohol is beneficial for your microbiome. And if if you like, outside of cancer treatment, you could take probiotic supplements. But before doing that, I'd recommend making sure you're drinking enough water, moving enough, having a really large range of plant foods and like whole grains as well. And you're reaching your fiber requirements, and the recommendation is like 25 to 30 grams a day, which most people aren't reaching. Unless you have a really like optimal healthy diet, you're probably not having over 20 grams of fiber a day. So yeah, you could see a dietitian to discuss this. And you definitely want to see a dietitian if you're looking at probiotic supplements. I'd just like to note that we obviously can't know what caused an individual person's cancer, and this kind of advice about reducing our risk of cancer is just about empowering people with modifiable factors. I did a presentation earlier in the year and did get some questions about reducing risk of cancer, so that's why I included it as well. So overweight and obesity contribute to increased risk of 13 different types of cancer. So when people talk about cutting out sugar or reducing your sugar intake, what's behind that is that like a lot of sugar intake leads to overweight and obesity, and it's that part that increases your risk of developing cancer. Once again, fiber-rich foods are associated with reduced cancer risk, whether it's recurrence or just reducing your risk to start with, particularly for bowel and like aerodigestive cancers. So like head and neck and esophageal cancers. I think it's really, really important with nutrition generally to think about the long term. So, not so much if you're currently getting chemotherapy, but if I see clients in like private practice and talk about reducing risk of chronic disease, it's not just about what you're doing in 1 week, it's what you're doing over months and years. So that's why if somebody comes in with high cholesterol and I give them dietary recommendations, which would include things like this, like high fiber, like limiting sugar intake, I'd say go and get another blood test in 3 months because it really takes 3 months to see changes. So yeah, don't give yourself too much of a hard time if you do have a lot of red meat or fried food on one day or 1 month. So that's pretty much the end of the presentation. I've just put a slide here about the dietitian service at Pancare. So as I said, it's a new service. I'm part of the PAN support team. So I work with 2 counsellors, a care coordinator and 3 nurses. That's been one of the highlights of the job so far, that it's a really, really lovely team. Everybody is very knowledgeable about upper GI cancer and really compassionate. It's a telehealth service, so I can do phone calls or video calls, and I work Wednesday, Thursday, Friday. To make an appointment, you can just call Pancare or you can go on the website. And I also do appointments with carers as well as patients or support people. So, you could have a combined appointment or you could have separate appointments.